Good evening, everyone. I welcome you all to today's WIMS Anesthesia Alumni Academic Activity. So today is its 37th academic program, monthly program. So the topic for today is oxygen therapy. And we have our distinguished speakers, Dr. Mohan and Dr. Puneeth, who will be speaking about these two topics. I welcome Dr. Mohan and Dr. Puneeth. The first topic is by Dr. Mohan Kumar. So, welcome, Dr. Mohan Kumar, sir.
Thank you, madam.
Dr. Mohan Kumar is an associate professor at ESI Medical College at Chennai. And he has done his MBBS from Bangalore Medical College and is MD from prestigious Jipmer Institute of Medical Sciences, Pondicherry. He also holds an European Diploma in Anesthesia and Intensive Care degree. He's passionate about pain medicine and is pursuing his PG certificate course in neuromodulation and pain management from Queen's Mary Institute, London. And he's been passionately teaching anesthesia for the past 14 years. And he's a postgraduate teacher for the past 7 years. And he has 10 research publications to his credit. Over to you, Dr. Mohan Kumar. Thanks for joining us again.
Thank you, madam. Thank you for that introduction. And at the first, I would like to thank Balabhaskar sir for giving me this opportunity. And also find it a very great initiative to share the knowledge, whatever we have amongst us. So I really appreciate it. And thank you again, sir, for this opportunity. So without wasting time, we'll move on to today's session. This is on oxygen therapy. So I'll be dealing with the principles of oxygen therapy, and my colleague, Dr. Puneeth, will be talking about the oxygen therapy devices. This will be the outline of today's talk. First, we'll discuss about the principles of oxygen therapy, thereby knowing the indications and how we administer it, which will be dealt by Dr. Puneeth, and any adjuncts along with oxygen administration, and also the complications associated with oxygen therapy. So we'll have a brief introduction. We know that oxygen has been in use clinical practice for more than 200 years now, and it is most probably the most widely prescribed medication by an anesthesiologist, both pre-hospital and hospital environments. As I told you, it should be used like any other drug. You should have a definite indication. You should know by what dose and by what route or mode you are going to give, and also for how long you are going to give. Now, people are under the misconception that oxygen is very good and it can be given at any length of time and for any dosage. It's not like that. There are complications associated with oxygen therapy. So we should be aware of it, and we should only administer whatever is required for that patient. And it is not just administering oxygen. We have to also focus whether the oxygen which we are administering actually is reaching the tissues, because that's where all the problems would arise. So therefore, a good cardiac output or circulation and hemoglobin is vital. So by definition, oxygen therapy constitutes administration of oxygen in a concentration more than ambient air, that is more than atmospheric air, about 21%. So the goal, as I told you, is not just to maintain adequate PaO2, but also to reduce the cardiopulmonary work, to alleviate hypoxia, and also to avoid any oxygen toxicity. So we'll know why oxygen has to be administered to any patient for that matter. And if we know that, we'll know when to administer this oxygen and also how to administer the oxygen. So why oxygen is very much important for us. We all know that aerobic metabolism is the energy producer in all the cells in the body. So for this oxidative phosphorylation in mitochondria, the oxygen is required, and in the presence of oxygen, each glucose molecule will give us around 38 ATP energy molecules. Whereas the same anaerobic metabolism, the same glucose molecule will just give 2 ATP, and to achieve this amount of energy, we are going to produce a lot of lactic acid, which will cause severe metabolic acidosis, which destroys most of our enzyme systems and also will have a great impact on the inotropy of the heart. And there is a level of PaO2 beyond which, and this is at the cellular level, mitochondrial level, It's about 1 to 2 millimeters of mercury, beyond which aerobic metabolism fails, and this point is called as Pasteur point. So as I told you, it is not just administering oxygen. Our concern should be on delivery of this oxygen to the tissues. So this delivery of oxygen is given by the equation CaO2 into cardiac output. This CaO2 is the content of oxygen in the arterial blood. Now, this content, oxygen content, is the amount of oxygen carried by 100 ml of blood. This constitutes both bound and dissolved hemoglobin. Bound hemoglobin is a product of hemoglobin into saturation of arterial blood of oxygen into 1.34. This 1.34 is the amount of oxygen which is carried by each molecule of hemoglobin. That is, each molecule of hemoglobin will carry about 1.34 ml of oxygen. So that's why to calculate this, we need to multiply by this factor. And dissolved oxygen is given by the formula 0.003 into PaO2. PaO2 is partial pressure of oxygen in the arterial blood. This 0.003 is the diffusion coefficient of oxygen for blood. That means each liter of blood will carry around 3 ml. So that we convert it into as 0.003. So if you replace this for arterial blood, if you replace in this formula for delivery, HB as 15 gram percent, which is normal, saturation around 97 to 100%. Normal PO2 is around 100 millimeters of mercury, and cardiac output is around 5 liters per minute in a 50 kg adult. So if you put all these numbers here, you'll get 20. This is per deciliter. So this cardiac output is 5 liters per minute, but if you convert it into deciliter, it will become 50. So overall, the delivery of oxygen in normal patient is around normal human beings is around 1000 ml per minute. So when this oxygen delivery falls short of cellular needs, then hypoxia is said to ensue. Now, by the above equation, we can know that hypoxia occurs if the arterial content of the oxygen falls, the cardiac output falls, or due to some reasons, the cellular utilization of oxygen is severely hampered, like in cyanide or carbon monoxide poisoning. So to define, hypoxia is oxygen deficiency in the tissues, that is reduced PbTO2. B2 is brain tissue, the partial pressure of oxygen in brain tissue. And hypoxemia is oxygen deficiency in the blood, that is reduced PaO2. Anoxia is total lack of oxygen in the tissues. So it is essential to know what is the type of hypoxia which the patient is having for us to further know what type of how we need to administer oxygen, how much to administer, and for how long to administer. So again, coming back to this formula, if you see here, notice here, when the hemoglobin falls, the DO2 falls, and hence the tissues will suffer hypoxia. So this we call it as anemic hypoxia. And when the PaO2 falls, there is hypoxemia, and this is known as hypoxic hypoxia. Then also there will be hypoxia at the tissue level. But if these are normal, still when the cardiac output comes down due to cardiac failure or septic shock or whatever it is, then there is something called stagnant hypoxia. So there is no problem with the oxygen content in the blood, but because the cardiac output is less, the delivery of oxygen to the tissues will get severely hampered and tissue will have hypoxia. And then we have this term called isotoxic hypoxia. Now here, total delivery will be normal. That is, content is normal, cardiac output is normal, but tissues are unable to utilize this oxygen. So delivery is normal, but the problem is at the cellular level. This happens, as I told you, in cyanide and carbon monoxide poisoning, wherein the mitochondria is not able to utilize the oxygen which is delivered to the tissues. So to understand further the hypoxia, we need to know about how this hypoxemia occurs. So for that, we should have a brief knowledge about what is called as oxygen cascade. Now, if you look at this diagram, now in the air, the oxygen concentration is around 21%. So that 760 millimeters of mercury is 1 atmospheric pressure. So if you calculate that, it will be around 159 millimeters of mercury. This is PiO2. But as it passes through the trachea, there will be some compensation because of that water vapor pressure, which is around 47 millimeters of mercury. So this will further come down to 150. But at the level of the alveolus, now we have to compensate for the other gas also which is present. This is constituted by the PaCO2, and R is the respiratory quotient. So this is around 0.8, and if you replace that, Now 150 minus PaCO2 is normally around 40, and R, the respiratory quotient, is around 0.8. So 40 by 0.8 will be around 50. So if you subtract that, it will finally end up at 100 millimeters of mercury. Now, because the gas, oxygen, has to pass through several layers, the alveolar epithelium, the interstitium, and the capillary endothelium, finally, we get end up of a PaO2 of around 92 to 97 millimeters of mercury in the arteries. And by the time it reaches the mitochondria, this will further drop down to 4 to 20 millimeters of mercury. So this stepwise downward cascade of partial pressures from normal atmospheric inspired partial pressure of oxygen to intracellular level is called oxygen cascade. Now, the size of any one step in the cascade may be increased under pathological circumstances and may result in hypoxia. So now you can easily understand, see, any reduced ambient pressure will high altitude. The pressure comes down, total pressure comes down. So the PiO2 also comes down. And even when the patient is not ventilating or there is hypoventilation, then also the FiO2 or the oxygen which is getting delivered will get reduced. And then this one is at the level of the diffusion. So this ventilation and circulation mismatch, or what you call as shunt and diffusion defect, all these will cause hypoxemia. So if you just remember this cascade, we can now know at what all levels there can be hypoxemia and what causes hypoxic hypoxia. And further, when you go back to the delivery formula, you know that hemoglobin is required, which causes anemic hypoxia if it is reduced. And then when it passes through the heart and heart then pumps out, the cardiac output also plays an important role in the delivery. So that causes stagnant hypoxia when there is cardiac failure. And finally, at the level of the mitochondria utilization, we end up in histotoxic hypoxia. So if you remember this cascade and that formula of delivery of oxygen to the tissues, we'll get to know where is the actual problem in this patient, and this will make our job easier in administering oxygen. So hypoxemia has been classified as mild, moderate, and severe. So 60 to 79 millimeters of mercury is mild hypoxemia. You know that on room air more than 80 is good enough. But in severe ARDS, in fact, it is even advised, suggested that target PaO2 of 60 is good enough for the cellular survival. But in pediatric patients, it starts from 60. So up to 60 is normal. So anything less than 60 is mild, between 50 to 60, I mean. So moderate will be 40 to 60 in adults and 40 to 50 in pediatric patients. And severe hypoxemia is less than 40 millimeters of mercury in both. Now, what we have to keep in mind is always interpret this PaO2 with respect to FiO2 which has been delivered. Now, PaO2 of 80 might be normal in a patient who is on room air, but the same PaO2 of 80, which appears to be normal in a patient who is receiving 100% oxygen, is called severe hypoxemia, because there, for a FiO2 of 100%, the PaO2 should be at least 5 to 6 times, so it should be around 500 to 600. So for a PaO2 of 500, 600, we are actually ending up with 80 millimeters of mercury. That means there should be some severe problem. So always make sure that you interpret this PaO2 with reference to the FiO2 which has been provided to the patient. So coming to the indications per se, any hypoxemia with PaO2, as I told you, PaO2 less than 80, or in case of severe ARDS, we can even take up to 60, and SpO2 less than 95%. In neonates, it is PaO2 less than 60 or SpO2 less than 90%. And as we all know, in anesthetic practice, we give it for pre-oxygenation so that we get more time, we buy more time for our intubation process. And then we have some specific indications for hyperbaric oxygen. So which I'll be briefly telling about the basis of hyperbaric oxygen. The device and other things will be dealt by Dr. Puneeth later on. So with this background, we now know that when to give oxygen. So whenever we want to increase pulmonary oxygen reserve, like in pre-oxygenation, to correct hypoxemia, as I told you, there are several causes in the cascade level how to correct this hypoxemia. And then to increase the dissolved oxygen, like in anemia, cyanide or carbon monoxide poisoning, to increase the oxygen, to compensate for the oxygen demand, in high altitude or shivering or thyroid crisis or even in hyperthermia, wherein Shivering actually is said to increase the oxygen demand by almost 200 times than the normal period or resting human being. So we have to take care of this increased demand also. So, and miscellaneous, because of distension, there is splinting and patient is not able to take up, and ends up in respiratory distress. Is there any contraindication for oxygen therapy? There is no specific contraindication, but the only thing is we need to properly judge the indications for oxygen therapy and appropriate therapy should be initiated. So when you are prescribing oxygen therapy, what you have to focus on is first, these are the questions which you need to ask in a stepwise manner. First, how much PaO2 is required in this patient without hampering the cellular aerobic metabolism? Next, how much FiO2 is required by the patient to achieve this PaO2 and by what mode it should be delivered. Now, suppose someone's respiratory efforts are good, but only the PaO2 levels are less, just supplementation of oxygen will be sufficient. But on the other hand, if someone's efforts are not good, then he may require some pressure support, for which we may have to rely on the CPAP or some ventilatory methods. And in some cases, wherein this poisoning, OP poisoning, OP compound poisoning, wherein the patient's respiratory muscles are totally paralyzed, he might be entirely dependent on the ventilator. So by what mode is also important. And then how much PaO2 will this raise? This I'll tell you in oxygen monitoring of oxygen therapy. And will this PaO2 actually improve the tissue PaO2 so that this PaO2 or whatever oxygen you're delivering to the tissues will be utilized by the tissues? So if you keep these things in your mind, it becomes easier for you to administer oxygen. So we have to understand some basic physics behind this oxygen therapy. The foremost is the Bernoulli effect and the Venturi principle. Now, this Bernoulli effect was first described for fluids passing through a tube. We know that average speed is given by the formula flow rate across the cross-sectional area of the tube or whatever container. So speed is greatest where lumen is narrowest. That is, the kinetic energy will be maximum when the lumen becomes narrow. And pressure is least where the speed is greatest. That is, the potential energy is less when the speed is great. Now, this is common sense. Now, when a fluid is passing through a tube like this, there are two forms of energy here. One, the kinetic energy, which keeps the fluid in motion. And the other one is the potential energy, which exerts pressure on the lateral walls of the tube. This is the potential energy and this is the kinetic energy. Now, when there is a constriction, the kinetic energy increases. Now, we all know that energy can neither be created nor be destroyed. So this increase in kinetic energy is only accounted by losing some potential energy. So suppose here the pressure, that is the pressure exerted on the lateral wall of the tube is around 100 millimeters of mercury, roughly I'm telling you. At this point, and the kinetic energy is at around 100. Now, when this becomes 150, this becomes 50. To sum up, it should be around 200. So here, if you notice, the pressure exerted on the lateral wall has now fallen down from 100 to 50. This is the Bernoulli effect, which was described for a fluid. Now, this has been applied for what is known as Venturi principle. Now, what happens here, if you create an opening here, you know there is a fall in pressure from 100 to 50. So there is minus 50 fall in pressure. So this will act, this will give a suctioning effect. And so if there is another fluid flowing outside this tube, it will be automatically sucked in because here pressure is falling down by 50. So the same this thing is applied in this Venturi principle. Now here oxygen is going, and when there is a constriction, there is an increase in kinetic energy. So this causes a fall in the potential energy here. So there will be a suctioning effect, and so the atmospheric air will be sucked in automatically. So this is known as Venturi principle. So when you see this mask, oxygen mask, you'll be seeing there will be some holes here for entrainment of room air. This is the fluid B of what we are looking here. Suppose this is fluid A and fluid B. So oxygen will be your fluid A and the atmospheric air will be the fluid B. So this is the basis of your Venturi devices. So as you see, now if you notice here, if the holes become much larger, so the entrainment will be much more and more dilution. So if you have noticed these Venturi devices, It will be dealt in detail by Dr. Puneeth later on in the devices. For usually the green one is said to have it's said to deliver 50%, 60% FiO2 at a flow of around 15 liters per minute. So this one will have very small aperture here, so that there is less entrainment of air, less dilution of oxygen. So more FiO2 is delivered to the patient. So, and this one is given a new, this is there was a mnemonic here: buy with only your real gold. So first is blue, white, orange, yellow, red, and green. Now normal is 21% atmospheric air. So blue will provide 24% if you give oxygen at a rate of 2 liters per minute. And white one will give FiO2 of 28% at a flow of 4 liters per minute. Orange 31% at 6 liters per minute. Yellow 35% at 8 liters per minute. Red 40% at 10 liters per minute. And green 60% at 15 liters per minute. Note that to achieve this FiO2, you have to give oxygen at this flow rate. Otherwise, it's not going to achieve this FiO2. And see, whatever oxygen which we are giving routinely is normobaric therapy. That is, we give it at atmospheric pressure. In some situations, we may have to use hyperbaric oxygen therapy. Here, oxygen will be delivered at around 2 to 3 atmospheric pressure absolute, ATA. So the basis behind this is, now when we looked at that DO2 equation, we found that in the dissolved oxygen in content of arterial blood, we noticed that it was 0.003 into PaO2. So at room air, at a PaO2 of 100 millimeters of mercury, blood will be carrying around 0.3 ml of oxygen. This is dissolved oxygen I'm talking about. Now, if you give 100% oxygen, the PaO2 will increase to 600. I told you it will become 5 to 6 times the FiO2. If you are giving 100%, your PaO2 will be around 500 to 600 millimeters of mercury. So in that case, it will become 1.8 ml. So there is not much of difference between this and this. But look at here, at 3 atmospheric pressure, your PaO2 is going to rise up to 2000 millimeters of mercury. At this PaO2, now we'll be delivering around 6 ml per 100 ml of blood. And this will be significant increase, almost increases by 50% when you compare to the normal blood or breathing at 100 millimeters of mercury. So this is the basis of hyperbaric oxygen therapy. So when you administer oxygen, how do you monitor whatever oxygen you are giving is adequate or not? So one is clinical monitoring. We know the signs of hypoxia. Patient will be restless. Patient will be in respiratory distress, tachypneic. There may be cyanosis. So we'll monitor the clinical monitoring. We'll monitor the clinical signs, the levels, conscious level, the respiratory and heart rates, blood pressure, peripheral circulation, and is there any cyanosis or not, or is there improvement in the cyanosis following oxygen therapy? Additionally, blood gas analysis and pulse oximetry is going to help a lot. In fact, there is something, this is named after Dr. Thota sir. This is Thota's virtual shunt table. Now, when most often when we intubate a patient and to put the patient on ventilator in ICU setup, we'll be giving 100% oxygen, and we won't mind to actually bring down the FiO2 further, because we think it's good for the patient. But if you notice here, see, if you give 100% oxygen for more than 12 hours, 80% oxygen for more than 24 hours, 60% oxygen for more than 36 hours, it's going to create these free radicals within the body, which is going to incite a systemic inflammatory response, like what happens in sepsis. So it is not that very safe to give so much high concentrations or high FiO2 to the patients. So how do you come down in ICU? Now, suppose a patient comes with severe hypoxia, you've intubated, you put the patient on 100% oxygen. Now we have to calculate the shunt in this patient. Now, suppose you are giving 100% oxygen, and now the PaO2, when you do an ABG after 20 minutes, PaO2 is around 250. Now, this patient does not require 250 PaO2. Now, as I told you, up to 80 is normal. And in fact, in severe ARDS, up to 60 is acceptable. So even if you take 80, since we don't want a PaO2 of 250, we'll assume 80 to be normal. I mean, we'll take 80 as acceptable this thing. So now, first, when you do the ABG with 100% oxygen, when you did ABG, it was 250. And for this, the shunt fraction given is 26%. Now, we don't want 250, I told you. So 80 is enough. So look at this column where you find 26. So 26 in 80 is here. So this corresponds to around 60%. So this patient actually requires 60% FiO2. So when you intubate a patient, put him on 100% FiO2, after 20 to 30 minutes, take an ABG. We need at least 20 to 30 minutes for equilibration to set in. So after 20 to 30 minutes, you do the ABG, you see what is the PaO2, and you calculate the shunt in this patient using this shunt table. And then, since we just want 80, go down and see for this shunt fraction, what is the FiO2 which is required. So by this, we can reduce the FiO2, unnecessary high levels of FiO2 to be given to patient, and we can only give whatever is necessary for the patient. So yeah, monitoring. Yeah, coming back to monitoring. So this blood gas analysis helps us to analyze whatever oxygen therapy we are giving is adequate for this patient, and we can also find out whether when to step down on the FiO2 and when to actually stop oxygen therapy. So apart from this, we have to also look at the serum lactate levels. As I told you, this is just about the PaO2 we are talking about. But there are so many other factors which finally end up in a reduction of oxygen delivery to the tissues, finally causing hypoxia. And whenever there is anaerobic metabolism, as I showed you in the initial slide, the serum lactate levels increases. So this is one of the measures, one of the ways of monitoring whether your oxygen pressure, oxygen therapy which you are giving is actually helping the patient or not. So if the serum lactate levels, obviously when there is hypoxia, to be very high. And if it is coming down significantly with your oxygen therapy, you know that the oxygen therapy which you are administering is good enough and is helping the patient practically. So this is how you monitor oxygen therapy. Now, it is not just about the oxygen which we are going to administer. There are several adjuncts. Coming back to this DO2 equation again. And please remember this equation. This is very, very essential. This is the crux of all the things which we are talking about oxygen and survival, cellular survival. So you have to remember this equation. So coming back to this equation, when you notice here, you have to improve the cardiac output. It is not just giving 100% oxygen. I told you at normal baric therapy, even you give 100% oxygen from 0.3 ml out of 20 ml, you can only increase it up to 1.5 ml. So there's not going to be much improvement in the total content of the oxygen in the arterial blood. So we have to take care of other things also. So one is the cardiac output. Suppose patient is in sepsis and is in shock. Our goal is also to increase the cardiac output, for which patient might require fluids. He might require inotropic support. And whenever there is anemia also added to this, so until we improve this, whatever oxygen you're going to give is not going to help the patient. So in anemic hypoxia, you have to take care of hemoglobin. Maybe patient will also require blood transfusions, blood and blood product transfusion. And we need to improve the lung conditions, give better humidification. Maybe when there is a severe lung infection, give antibiotics, bronchodilators, and think of tracheostomy also later on. So, and also you should take care to reduce oxygen demand, especially in sepsis. When you know there is severe ARDS due to any reason, it is better to paralyze the patient and reduce the respiratory work. See, when there is severe sepsis, and patient is left to breathe spontaneously, there will be a lot of work done by the patient, which consumes a lot of oxygen. So the demand is very high in them. So when you know that this patient cannot be extubated in the near future in another 2-3 days, better paralyze the patient, sedate the patient, and give oxygen, because that's going to come down on the oxygen demand, which is really going to help the patient's overall condition of the patient. So these are the adjuncts in the oxygen therapy which you have to keep in your mind. So is it safe? no, it's not actually safe. There are so many problems associated with oxygen toxicity. I told you, one is the free radicals which are going to be released within the body, which will incite a systemic inflammatory response. So we need to bring down the FiO2 as early as possible and maintain only whatever is necessary for the patient's cellular survival. So this toxicity mainly involves the CNS and lungs. CNS system is affected when you give very high concentrations in short bursts of time, like in hyperbaric oxygen therapy. The common problems include tremors, twitching, even convulsions. The GTCS can happen. Patient may even go in for coma. And when you are giving a low concentration oxygen for a longer time, usually the respiratory system is going to get affected. There can be acute tracheobronchitis, absorption atelectasis, and also CO2 narcosis in CO, especially in COPD patients. Other than that, in premature infants, there can be retrolental fibroplasia, retinopathy of prematurity, and also it can depress the cardiac contractility. I told you these free radicals can incite a systemic inflammatory response, which is going to reduce the contractility of the heart and suppresses the hemopoiesis. And there is also an additionally fire hazards which can happen. Now, problems with hyperbaric oxygen therapy, there can be barotrauma, oxygen toxicity related to that, fire hazards, claustrophobia, and sudden decompression sickness. So to summarize, oxygen is a life-saving treatment, no doubt, but it should be used like any other drug. You should have a definite indication. You should know the proper dosing, by what mode you are going to give. And you should also be aware at the back of your mind about the adjuncts to improve further delivery of oxygen to the tissues, and also the complications which can arise from your oxygen therapy. So I'll end this session. Dr. Puneeth will further talk about the oxygen therapy devices. Thank you.
Thank you, Dr. Mohan. That was indeed a very detailed and very easily and understandable to the postgraduate, especially the Bernoulli effect and the basic principles. Yeah, now I'd like to invite Dr. Puneeth Pujar, who is an assistant professor at ESI Medical College. Dr. Puneeth, can you please start sharing your screen? Dr. Puneeth Pujar was our ex-postgraduate. He did his anesthesia from WIMS Medical College. And after that, he has worked in multiple places like in Hyderabad and Raichur. And currently, he is working as an assistant professor at ESI Medical College. And his interest is again pain medicine, and he's pursuing his pain fellowship. Puneeth, over to you.
Thank you, ma'am. I'll just share the slide.
Screen, Puneeth.
Screen, yeah. Can you
Yes.
maximize the screen?
Slideshow.
Slideshow.
Yes. Sir, I'm a visitor.
No, Puneeth, you're
Full screen
audible.
PowerPoint, I think we should go to
Slideshow.
Yeah, slideshow.
Yes.
The one
Sir, I'm just
Right bottom hand.
just beside the volume, icon.
I missed. Yes. Screen sharing is paused. It is showing now. Just.
I the other mail click on.
Yeah.
That's right.
Right.
Yes. Sir, I'm able to hear. Sir, audible. Sir, it's audible, sir.
Yes,
Yes,
Puneeth,
perfect.
you are audible.
Yes. So, good evening, everyone. So, today's my topic is on oxygen delivery devices. I thank Dr. Balbhaskar sir, Dr. Josna ma'am, and Dr. Srinivas sir for giving me opportunity to speak in the VAA group. So, coming to oxygen delivery devices. So, here I'll be dealing with mainly with the many oxygen delivery systems. Okay, there are many are there. The important ones I'll be dealing here. So oxygen delivery system is a device which is used to administer, regulate, and supplement oxygen to a subject to increase the arterial oxygenation. Just a minute. Slide is being.
You can just
Click on the screen, Puneeth.
click on the screen also, it will go to the next.
Yes. So here the oxygen delivery devices, they are divided based on the divided into normobaric and hyperbaric based on the atmospheric pressure. So in normobaric, we have again low dependency, medium dependency, and high dependency system. In low dependency, we have variable performance and fixed performance devices. So based on the type of respiratory pattern, we will be using the type of devices. So type of normobaric or oxygen delivery devices. Here we have low dependency, medium dependency, and high dependency system. In low dependency, it is here supplemental oxygen is alone is sufficient to correct the hypoxia, which is used especially in case of spontaneous breathing patient. And medium dependency, we have supplemental oxygen and a degree of respiratory assistance is required. It is used especially in patients who are on spontaneous breathing with additional respiratory support. We have CPAP. In high dependency, here supplemental oxygen and full respiratory support is required. Here, the patients have absent spontaneous respiration. We use mainly like non-invasive positive pressure ventilation or intermittent positive pressure ventilation. So selection of devices. Here, 3 P's we have to remember: the purpose and the patient and the performance. So goal is to match the performance characteristics of the equipment to both the objectives of the therapy, that is purpose, and the patient's special needs. So purpose is to improve the arterial hypoxemia. And what are the patient factors for selecting the oxygen delivery devices? It is based on the severity and cause of hypoxemia, patient age group, that is infant, child, or adult, and the degree of consciousness and alertness, presence or absence of tracheal airway, stability of minute ventilation, mouth breathing versus nose breathing patient. So coming to low dependency system, we have variable performance devices or low flow devices, and we have fixed performance devices that are high flow devices. So choice of delivery system is based on the, already I have told, degree of hypoxemia, requirement for precision of delivery, patient comfort, and the cost. So coming to low dependency oxygen delivery systems. So mainly in low flow oxygen devices, they cannot deliver a constant FiO2. Flow rates of 6 to 8 liters per minute should be kept. Here the mixture of oxygen and room air is being delivered. So here the FiO2, it varies with the tidal volume. That is, in case of shallow breathing patient, there is less entrainment of room air and higher FiO2 is delivered to the patient. So in case of deep hyperapneic breathing patient, more entrainment of room air is seen and less FiO2 is delivered. So examples we have nasal cannula, oxygen mask with the reservoir bags, and the non-rebreathing mask. So in high flow devices, they maintain a constant FiO2 delivering O2 at very high rate. Flow usually 4 times the actual minute volume is being delivered. It is used especially in patients treating who are hypoxic patients who are dependent on hypoxic drive to breathe and require controlled increments in FiO2. Especially used in young and vigorous patients with hypoxemia with the ventilatory requirement exceeding the capability of low flow systems. Here mainly we use jet mixing, Venturi mask, reservoir nebulizers, oxygen blenders. So in this graph, so in low dependency system, we see the 3 blocks. In the A block shows the low flow devices. There is variation in the FiO2 being delivered. In the B block, we can see there is constant flow of FiO2. In case of reservoir device, there is also a constant delivery of FiO2. So why there is variation in the FiO2 in case of low flow devices? So when the patient breathes rapidly, when compared to the patient with normal breathing patient, so consider the patient is having 40 breaths per minute and generating a tidal volume of 750 ml per breath per minute. So when it is compared with 10 breaths per minute with a tidal volume of 500 ml breaths per minute, when oxygen flow of 2 liters per minute is kept. So what happens here is, in case of the patient having more respiratory rate and tidal volume, the FiO2 delivered is very less, that is around 26%, with the flow meter set to 2 liters per minute. But when the flow meter same at 2 liters per minute, it is delivered to a normal breathing patient, the FiO2 delivered is about 53%. 53%. So the respiratory pattern also depends on, it's very important for the delivery of FiO2. So coming low dependent system, we have low flow systems and high flow systems. Here we have in low flow systems, nasal cannula, simple mask, reservoir mask. In reservoir mask, we have again partial rebreather mask and non-rebreather mask. In again, we have high flow systems, we have Venturi mask and high flow nasal cannula and blenders. So coming to low flow devices, here mainly we have nasal cannula, prongs are spectacles, nasal catheters, transtracheal catheters, face mask, partial rebreathing mask, as shown in the table, non-rebreathing mask and tracheostomy mask. So coming to the in low dependency, again we have no capacity devices. That is, there is no storage capacity. Here the physiological dead space is reduced and no apparatus dead space is seen. And enrichment depends upon peak inspiratory flow rate and the O2 flow rate. Examples we have nasal catheters and prongs. So coming to nasal cannula. So we have variety of nasal cannula. So nasal cannula, it consists of two soft prongs attached to an oxygen supply tubing. A flow rate of 2 to 4 liters per minute delivers an FiO2 of 28 to 36%. So how we want to calculate the FiO2 in case of nasal cannula? So using this formula, 20% plus 4 into oxygen per liter flow. So if you use this formula, we can calculate the FiO2. Here there is no increase in FiO2 if flow rate of more than 6 liters per minute is kept. And in nasal cannula, nasopharynx acts as a reservoir for oxygen. If patient breathes through mouth, airflow produces a Venturi effect in the posterior pharynx, entraining oxygen from the nose. So the nasal cannula is available in different sizes and different prong shapes. So what are the different sizes and different shapes in case of nasal cannula? We have curved prongs, which helps in improved anatomical fit. We have flayed prongs, which slow down the flow of oxygen. We have a combination of both, that is curved and the flayed prongs. So we have both the benefits of the first two. We have straight prongs. We have curved prongs with the ear guards, which helps in improved anatomical fit and patient comfort. So already I told you the prior formula. So estimation of FiO2 provided by the nasal prongs. So each liter in increase in oxygen flow rate, the FiO2 increases by 4%. Here I'll give by using an example. A patient using a nasal cannula of 4 liter has an estimated FiO2 of 37%. That is, when 4 liter is oxygen flow is kept, if you multiply by 4, we get 16. If it is added with 21, the amount of FiO2 delivered to the patient can be calculated, which is about 36%. So what are the advantages of nasal cannula? It is ideal for patients on long-term oxygen therapy, lightweight and comfortable. The patient is able to speak, eat and drink. Humidification is not required, and it is of low cost. So disadvantages: cannot provide a high flow oxygen, irritation and cannot be used in case of nasal obstruction. FiO2 varies with the respiratory effects. High flow rates are uncomfortable. So coming to nasal catheters. So in this figure, the size of the nasal catheter is being measured. So in this slide, the catheter tip is placed just behind the uvula. So nasal catheter, it is a single lumen catheter which is lodged into the anterior nares by a foam collar inserted just above the uvula. Here flow rates of 2 to 3 liters per minute generates an FiO2 of 35 to 40%. And we have to be careful. Like in case of nasal mucosal tear, there might be a risk of surgical emphysema. So deep insertion can cause air swallowing and gastric distension. Must be repositioned every 8 hours to prevent breakdown. So it has no advantages over nasal cannula. So coming to medium capacity devices. Here we have simple face mask, like the parts of the simple face mask includes an oxygen inlet and exhalation ports. So transparent mask provided with side holes, which has a reservoir capacity of 100 to 250 ml. Different oxygen flow rates result in high variable and unpredictable FiO2. Here, rebreathing can occur with oxygen flow rates of less than 2 liters per minute, or if minute ventilation is very high. So the oxygen flow rate in case of simple face mask should be more than 2 liters. 4 liters per minute of oxygen flow delivers an FiO2 of 35 to 40%, providing there is a normal respiratory pattern. And again, flow rates greater than 8 liters per minute, it does not increases the FiO2. So what are the advantages of simple face masks? They are less expensive, can be used in mouth breather patients. So disadvantages: uncomfortable, require tight seal, do not deliver an high FiO2. FiO2 varies with breathing effects, interfere with eating, drinking, and communication. Difficult to keep in position for longer duration. Chances of rebreathing are very high. So coming to high capacity devices, we have partial rebreathing mask and non-rebreathing mask. In partial rebreathing mask with a reservoir capacity of 1 liter, oxygen flow directly into the reservoir bag, which fills during exhalation. Designed in such a way that it captures the exhaled gases from the initial part of the expiration, that's from the dead spaces. Useful in situations where supplies are limited. So here we'll see the partial rebreathing mask. So we have the mask and the reservoir bag. So there is no wall between the mask and the reservoir bag, and we have the exhalation ports for the exhaled gases to exit. So it delivers an FiO2 between. Flow should be kept to remove the exhaled carbon dioxide and to refill the oxygen reservoir. This is very important. Flow rate must be sufficient to keep the bag half to 1/3 inflated at all times. So what are the advantages of partial rebreathing mask? Inspired gas not mixed with room air. Partial patient can breathe the room air through exhalation ports if oxygen supply gets interrupted. So disadvantages: more oxygen flow does not increases the FiO2, interfere with eating and drinking. Coming to non-rebreathing mask, here it is provided with the one-way wall between the mask and the bag and the exhalation ports. So this is the main difference with that of partial rebreathing mask. Here FiO2 of 95% can be achieved with oxygen flow rates of 10 to 15 liters per minute. Ideally, non-rebreathing mask should not be allow entrainment of air, but because of safety concerns, one of the two exhalation ports is not provided with the valve. What happens here? Here the parts like between the face and the mask, we have the valve, and in the exhalation ports also we have valve. Because of safety concerns, one of the exhalation valve will be absent. So coming to here, the higher oxygen supply rates are required. Desirable in cases where rebreathing of carbon dioxide would be detrimental. That is in case of head injury patients. Best results will be achieved by adequate flow rates such that the reservoir bag empties by no more than a third during inspiration and by best seal possible between the mask and the face. So advantages: highest possible FiO2 without intubation, suitable for spontaneously breathing patients with severe hypoxia. So what are the disadvantages? It is expensive, required tight seal and uncomfortable, interfere with eating and drinking, not suitable for long-term use. Malfunction can cause carbon dioxide buildup and suffocation. So here the summary of the low dependency and medium dependency devices. So we have the flow rates, how many flow liters per minute should be kept, and the amount of FiO2 delivered to the patient. So in case of nasal cannula, up to 44% of FiO2 is achieved with a flow rate of 6 liters per minute, up to 6 liters per minute. In case of oxygen mask, up to 8 liters per minute, can FiO2 of 60% can be achieved. Mask with a reservoir bag, up to flow rates of 6 to 10 liters, FiO2 of 60 to 90% can be achieved. In case of non-breathing mask, flow rate of 4 to 10 liters per minute, FiO2 of 60 to 100% is achieved. So coming to very high capacity devices, we have oxygen wood. Here the volume is about more than 1500 ml. Here flow rate of 7 to 15 liters per minute is kept and FiO2 of 21 to 70% is achieved. So other very high capacity devices include oxygen tent or hood. So coming to high flow or fixed performance devices. So here mainly we see Venturi mask. It is based on the Venturi modification of Bernoulli's principle, and gas flow is sufficient to meet the demands of the patient, not synonymous with high concentration of oxygen. So it mainly consists of a plastic body with holes on the both sides, and the proximal end of the mask consists of a Venturi device. The Venturi devices are color coded and marked with recommended oxygen flow rate to provide the desired oxygen concentration. We have also a calibrated adjustable Venturi device which can be used to deliver the desired FiO2. So already prior, Dr. Mohan sir has shown this figure. So what happens here? We have different color coded Venturi devices. So here mainly I'll tell the principle. So already sir has told the principle. So I'll be just explaining briefly. So we have an adjustable Venturi device. Here the dial, if we rotate the dial, the amount of FiO2 delivered will be changed. And the size of the aperture, that is the hole, it changes with the change in the dial, and the amount of FiO2 delivered will also be changing. So this slide will explain about the principle of the Venturi mask. It delivers a fixed concentration of oxygen. The size of the constriction determines the final concentration of oxygen for a given flow. So here the constriction, I'll explain in the next slide. As a forward flow of inspired gas increases, the lateral pressure adjacent and the perpendicular to the vector of flow decreases, resulting in entrainment of gas. So these lines are very important. The smaller the orifice, the greater the negative pressure is generated. So the more ambient air is entrained and lower the FiO2. So what happens? Sir has explained already Bernoulli's and Venturi's principle. So what happens here? The size of the constriction is very important. So if the size of the constriction is more, the velocity of the gas flow is more, and the air entrainment will be more, because the pressure drop at the sides of the sides will be more and more air is entrained. If the size of the constriction, it is big. So what happens? The pressure drops will be less. So less amount of air is being entrained and less amount of oxygen is being diluted, and more amount of oxygen, that is higher amount of FiO2 will be delivered to the patient. So Venturi mask is also called as jet mixing Venturi mask or air entrainment mask. So because of the high fresh gas flow rate, the exhaled gases are rapidly flushed from the mask via its holes. Therefore, there is no rebreathing or no increase in the dead space. These masks are recommended when a fixed oxygen concentration is desired in patients whose ventilation is dependent on the hypoxic drive. So this slide is very important. So based on the color coding, how much of the amount of air is being entrained and how much of the total flow is delivered to the patient. So coming to the blue color, it delivers an FiO2 of 24%. The amount of air being entrained is 51 liters per minute. When the and the total flow to the patient is 53 liters per minute. When it is compared with that the highest, that is the green Venturi device. Here the FiO2 is 60%. The amount of air entrained is 15 liters per minute. When the amount of air entrained compared with that of the blue one, here the amount of air entrained is 51, but in case of green it is 15. So when 51 liters means the more amount of air is being getting diluted, so less amount of FiO2 is being delivered to the patient. Here the amount of air being diluted is very less. So the FiO2 delivered to the patient will be more. So how do you calculate the device flow rate? So with the help of air oxygen ratio, we can help to calculate the device flow rate. So the air oxygen ratio can be calculated with the help of the formula, that is 100 minus FiO2 divided by FiO2 minus 21. So at FiO2 at 40%, the air oxygen ratio will be at 3.2. So the flow meter, when it is set at 10 liters per minute, so when it is multiplied with 3.2, that is the amount of air entrained, 32 liters per minute we get. And when it is when we calculate the total flow, the amount of air entrained, when we add with the flow meter flow, we will get the total amount of oxygen delivered to the patient. That is the flow delivered to the patient. So what are the advantages of Venturi mask? Fine control of FiO2 at fixed flow, flexible, reliable and precise FiO2 is delivered. High flow comes from the air, saving the oxygen cost. Can be used for low flow FiO2 also. Helps in deciding whether the oxygen requirement is increasing or decreasing. So what are the disadvantages? It is uncomfortable, expensive, cannot deliver high FiO2, interfere with eating and drinking. So coming to high flow nasal cannula, this is also very important device. Delivers heated and humidified oxygen by a special device, that is VAAA. Rates up to 8 liters per minute in infants and up to 40 liters per minute in children and adults are used. In patients with respiratory distress or failure, oxygen by humidified high flow nasal cannula may be better tolerated than by a face mask. So high flow nasal cannula, it washes out the carbon dioxide in anatomical dead space, creates a positive nasopharyngeal pressure. FiO2 remains relatively constant because the gas is generally warm to 37 degrees Celsius and completely humidified. Mucociliary functions remain good and little discomfort is reported. So here you can see the setup of the high frequency nasal cannula. So what happens here? We have the air oxygen blender along with the flow meter. Here the air is being humidified and it is delivered to the patient with the help of the nasal cannula. So this complete unit is very important. So what are the indications of HNMC? So it can be used both in the ICU and the anesthesia setup. In case of ICU setup, patients like acute hypoxemic respiratory failure patients, patient with mild to moderate respiratory distress, patients who have poor compliance with oxygen therapy via mask, to facilitate weaning from invasive or non-invasive ventilation, and patients requiring high FiO2. In case of anesthesia setup, as an alternative to non-invasive ventilation, we can use in case of tubeless surgery, that is in case of tubeless procedure, that is in case of bronchoscopy, in case of pre-oxygenation for intubation, in case of post-operative respiratory support, in case of exacerbation of chronic obstructive pulmonary disease, pneumonia, pulmonary edema, asthma. It was very useful in case of COVID patients also. Can be used as a part of palliative care and in do not intubate patients. So what are the contraindications? Inability to protect airway. So patients who are having less level of consciousness, it is avoided. Presence of base of skull fractures, maxillofacial trauma, nasal obstruction, that is patients having choanal atresia, nasal polyps and adenoids, life-threatening hypoxia and foreign body aspiration. So here is the picture of high flow nasal cannula. Coming to blending systems, here when high concentration of oxygen flow is required, which mainly consists of an inlet for pressurized air and oxygen source. Here the gases are mixed either manually or with the help of blender. And output we have mixture of air and oxygen with precise FiO2 and flow. Here the blending system mainly used for spontaneously breathing patients requiring high FiO2. Here the blending system unit we can see. So inlet for oxygen air and outlet for oxygen and the desired amount of flow. So what happens here, the oxygen air, they are mixed either manually or with the help of blending systems. We have also alarms, which in the case of oxygen failure or in case of any drop in pressure. So coming to long-term oxygen delivery systems, we have gas supplies such as oxygen concentrators, compressed gas, liquid oxygen. So delivery devices for long-term oxygen therapy includes most of the low-flow devices, as I previously explained, designed to conserve home oxygen by improving the efficiency of oxygen delivery. So we have nasal cannula, reservoir nasal cannula, electronic conserving devices, that is pulse devices which are based on fixed volume and breadth. We have demand devices such as variable volume and length, and we have transtracheal catheters. So reservoir nasal cannula can be used for long-term oxygen therapy. Here the oxygen reservoir is very close to the nares. So coming to transtracheal catheters, So transtracheal catheters, they reduces the total oxygen usage by 50 to 75%. So lack of nasal or facial irritation due to the flow. Infrequency of catheter displacement is seen in sleep. So disadvantages include infection, mucus plugs, which may occlude, which are potentially fatal, and catheter breakage is also one of the potential. So devices based on the performance. So what are the devices I have explained? I have just summed up. So low flow, that is up to 35% of FiO2 delivered. Devices such as air entrainment or Venturi mask. And in case of variable devices, we have nasal cannula and nasal catheters. 35 to 60% of FiO2, we can use air entrainment and Venturi mask or blending system in case of fixed performance devices. In case of variable performance, we can use simple oxygen mask. So FiO2 of more than 60%, we can use blending system, partial rebreather mask and non-rebreather mask. So already sir has explained about hyperbaric oxygen therapy and their indications and contraindications. I'll just explain once more. Here, hyperbaric oxygen therapy is defined as administration of 100% oxygen to a patient placed inside a chamber, pressurized to greater than 1 atmospheric pressure. That is where oxygen dissolved in the arterial blood plasma is increased in amount and it is carried to the different tissues. So already sir has explained, Mohan sir has explained the basis for oxygen therapy. It is mainly we need to increase the amount of dissolved oxygen in the plasma. So it is very important to increase the atmospheric pressure and also the amount of dissolved oxygen in the blood. So what are the physiological effects of hyperbaric oxygen therapy? So to decrease it will help in decrease the bubble size, that is Boyle's law. It will increase the hyperoxia of blood, that is increasing the partial pressure of oxygen, increasing the blood oxygen content. So enhanced host immunity stimulates neovascularization, inhibits endothelial adhesion of neutrophils in injured tissues, antibacterial against anaerobic organisms. So these last four things which will helps in wound healing also. So what are the indications? In acute conditions such as decompression sickness, air embolism, carbon monoxide poisoning, severe crush injuries, thermal burns, clostridial gangrene infection, acute arterial insufficiency, necrotizing soft tissue infection, and ischemic skin graft or flap. In chronic conditions, we have radiation necrosis, diabetic wounds of the lower limb, refractory osteomyelitis, actinomycosis. So what are the types of hyperbaric oxygen therapy? We have monoplace and multiplace. In case of monoplace, the patient is placed in the pressurized chamber. In multiplace, many patients are placed in a single chamber and the hyperbaric oxygen delivered to the patient. So what are the advantages of monoplace chamber? Patients are cared individually, thereby maintaining privacy. Isolation of patients ensures that there is no amplification or spread of disease from other patients. So how do you deliver the hyperbaric oxygen therapy? So process of treatment. So there is initial compression for 30 minutes. Treatment is for 90 minutes with air breaks. 10 minutes for every 30 seconds is standard. And decompression is done again for 30 minutes. So total duration of 90 minutes, 30 minutes, the procedure is done. 10 minutes break is taken. Again, the 30 minutes procedure is being done. So here 100% of oxygen is being used and pressures. Most of the time we use the 2.4 atmospheric pressure. Maximum pressure tolerated is 3 atmospheric pressure. And if you use more than 4 atmospheric pressure, it induces seizures. So in case of wound healing also, we can use topical oxygen therapy. So what are the contraindications for hyperbaric oxygen therapy? That is untreated pneumothorax, which may be converted into tension pneumothorax. The patients who are on cisplatin, there will be delayed wound healing. And the patients who are on disulfiram, here it blocks the superoxide dismutase, which decreases the body ability to neutralize oxygen free radicals. And there is hyperoxic induction of cytochrome P450 and potential for pulmonary toxicity. So what are the relative contraindications? History of spontaneous pneumothorax, history of thoracic surgery, concurrent URTI, emphysema and COPD, patient with seizure disorders, pregnant patients. So what are the complications of hyperbaric oxygen therapy? So mild, it includes claustrophobia, in case of monoplace chamber and headache. More serious complications include sinus damage, ruptured middle ear, and lung damage. So major complications include convulsion and respiratory failure. So these are the oxygen delivery systems we commonly use.
Thank you, Dr. Puneeth. And the chat box is open for any queries. So we have